Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome back to the UI Creds 2024. First of all, let's say thanks to Allah Subhanahu wa Ta'ala who has been giving us happiness, health, and mercy so we can attend in this event today. Salawat and salam always be delivered to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness until the brightness like now. The Honorable Lecturer and all of participants, thank you very much on your present and active participation since day one, and we hope that the same energy for today's session. Today, we will continue on our lecture about participle and pharmacokinetics and ATME with Bapak Dr. Apoteker Catur Jatmika MSI. Will be moderated by Bapak Dr. Bayu Ardiansah, SSI MSI. Bapak Dr. Bayu Ardiansah, SSI MSI, is a lecturer at Chemistry Department, Universitas Indonesia. He has recent interest at synthesis organic chemistry and natural product chemistry. She got bachelor and master degree from Chemistry Department, Universitas Indonesia, and PhD degree from Nara Institute of Science and Technology, Japan. She has been a chemistry lecturer at Universitas Indonesia since 2016. She had many science publications. One of them is Recent Trends in Synthesis and Bioactivity of Coumarin, Coumarin Chalcone, and Coumarin Triazole Molecule Hybrids. Ladies and gentlemen, I will give time to our moderator, Bapak Dr. Bayu Ardiansah, SSI MSI. To Bapak Dr. Bayu Ardiansah, SSI MSI, time is yours. Natural product chemistry. She got bachelor and master degree from Chemistry Department, Universitas Indonesia, and PhD degree from Nara Institute of Science and Technology, Japan. She has been a chemistry lecturer at
Okay, thank you very much, Miss Hilna, for kind introduction. Honorable guest lecturer, Dr. Catur Jatmika, Master of Science, Dr. Nurdini binti Muhammad Saleh as UM Coordinator for UI Creates Program 2024. And also lecturers, faculty staffs who attending this virtual course. Dr. Heri Cahyana from Universitas Indonesia and other lecturer. And also all beloved participants of UI Creates program. First of all, I'd like to welcome you all to this virtual course 4 in the UI Creates program. And today we will have presentation from prominent speaker. He is Dr. Apoteker Catur Jatmika MSI. He is senior lecturer from the Faculty of Pharmacy, or Pharmaceutical Science at Universitas Indonesia. Before we start the lectures presentation, let me introduce our speaker today, Dr. Apoteker Catur Jatmika. Received his Bachelor of Pharmacy degree from Institut Teknologi Bandung until his Master of Science in Pharmacy. And then the latest education is Doctor of Science in Pharmacy, obtained in 2020 from Nara Institute of Science and Technology, Japan. So yeah, he is my best friend and come from same university. He has work experience from 2012. He is a lecturer at the Faculty of Pharmacy, and start from 2022, he is head of the pharmacist profession study program at the same faculty. Dr. Satur Jatmika has many publication. This is only the recent publication, exploration of ferulic acid and its derivative as potent anti-tyrosinase, a systematic review. And then the second one is development of colorimetric paper sensor for mercury detection using cyanuric acid conjugated gold nanoparticle. And then the third and fourth published in the Dalton Transaction and Chemistry Letter about the HOVIDA group catalyst. So because of his many experience in pharmaceutical science, we very happy to have him in this lecture series. And yeah, without further ado, I will give the time for Dr. Catur Jatmika to present his material about principle of pharmacokinetic and ATME. Good morning, Dr. Catur Jatmika. How are you
Good
today?
morning. Thank you very much for inviting me here. So, okay, can I start now, Dr. Bayu?
Yeah, please, Dr.
Ah,
Catur
okay.
Jatmika.
Okay, thank you very much. Okay, thank you again, Dr. Bayu, for the kind of introduction. Honorable lecturer, Dr. Harry, and Dr. Lecturer from the UM. So, good morning, everyone. Jatmika, an academic staff from the Faculty Pharmacy Universitas Indonesia. So basically, I joined the Universitas Indonesia in 2013. And then after that, I study doctoral degree on 2017 to 2020 in Nice, Japan. And I come back, and in 2022, I become a head of pharmacy study program until now. So I was asked by Dr. Bayu to deliver materials on pharmacokinetics about the absorption, distribution, metabolism, and elimination. And I got the information from Dr. Bayu that majority of this participant of this class is basically from the chemistry study program. From the level 2, second level or third level. So I assume that you didn't get any pharmacokinetics material at your college curriculum. So on this occasion, I will convey the basic of the pharmacokinetics and introduction related to the absorption, distribution, metabolism, and eliminations. Let me share my presentation first. Okay. Okay, can you see my presentation?
Yes, doctor.
Okay, thank you. So actually, honestly, I should tell you that a pharmacokinetics is itself actually around level 2 or level 3 course in the pharmacy undergraduate study. So it's with a load of 2 or 3 credits. There is also a hands-on about the pharmacokinetics. It's basically like just almost same like the analytical chemistry. So you do analyze the drug substance from the blood or the urine to get, and then you have to calculate the several pharmacokinetics parameters to, and then you conclude what is what is happening to the drug. So it is impossible to convey all the aspect of the pharmacokinetics today in one meeting just for 100 minutes. Therefore, today we will not discuss about the aspect for those calculation or something like a calculation, mathematical calculation. So we are not dealing with the mathematical equation at all. It's just a basic introduction of the pharmacokinetics. There's no, maybe I try to explain several things as a several parameters such as clearance, volume distribution, half-life, or maximum concentration, but we will not learning about how to calculate them. So we will only learn the basic of the aspect of the pharmacokinetics. During this lecture, please feel free to ask questions anytime. You can ask directly by pressing the raise hand button or typing the questions in the chat box. Okay, let me start. Okay, we will start at the definition of the pharmacokinetics. So pharmacokinetics is actually the study of the fate the drug in the body, or if we just call the what the body does to the drug. What will happen when the drug is entered to the body? So in a simpler way, this is about the study about the disposition of the drug. So whether the drug is will be metabolized, will be absorbed, will be distributed, or expression, it will be learned in the field of the pharmacokinetics actually. So basically, pharmacokinetics is related to the biopharmaceutic and pharmacodynamics. So at first, before we go to the scope of the pharmacokinetics, there's also a biopharmaceutic. What is the biopharmaceutic? What biopharmaceutics is the study that involve what happened to drug when they are consumed until the absorption process. For example, if you consume a tablet, the tablet will be degenerate, will be diluted, and after the diluted, the drug will be attached to, for example, to the GI, gastrointestinal tract, and then it will be absorbed. So the scope of the biopharmaceutic study is from the drug after it consumed, and then it finishes after it is absorbed. And then it is continue the scope of learning with the pharmacokinetics. So basically pharmacokinetics is also learn in the start about the absorption, and then it will be study, it's also study about the distribution, metabolism until the drug is eliminated from the body. And then there's also a pharmacodynamic. So pharmacodynamics is a little bit different because it's related to the pharmacology. So basically the pharmacodynamics is study how the drug affect the body. So usually the pharmacodynamic study start after the drug is entered the bloodstream. So after the drug entered the bloodstream, so we expect that the drug will have some efficacy, will have some effect that will repair the body function, or it generates some mechanism to repair or to induce something else so that can alleviate the disease. So that is the scope of the pharmacodynamics. So if we study about the pharmacokinetics, we will not be separate from the following four things. That is absorption, distribution, metabolism, and excretions. And as for the study related to the toxicity, is actually an additional discussion. By studying pharmacokinetics, parameters such as Cmax, concentration maximum, clearance, we can determine whether the drug has a strong potential to provide a toxic effect on the body. This makes some literature include, this actually makes some literature, several literature include the toxicity study in the discussion of the pharmacokinetics. So I want to start by the process of the drug development. So as you can see that the drug, maybe you have been explained it before, you learned it before, that the process of the drug development is a long and require a lot of time and money. The developments, the stage development include an in silico study, and after that in vitro study, and then continue to the in vivo, and then go to the clinical research. For example, at the first stage, the discovery and development involving the synthesis study, and then also maybe high throughput screening. For example, we want to identify the good candidate with the much library, so we do some screening, fast screening, to eliminate, to select, to do some selection, what a good candidate that can be used for the next step. So after that, for example, some in silico study and in vitro study, we go to the preclinical research. In the preclinical research, we do some animal testing. So for example, the toxicity study, and then for efficacy study, to select, do some selection, which candidate that have a good safety and the good efficacy to be continued to the clinical research. And after that, in the third phase, there is a clinical research. The clinical phase of the drug development actually is divided into the three phases. There are phase 1, phase 2, and phase 3. Phase 1 is conducted with the healthy patient. Phase 2 is conducted with the patient with the disease, and also patient 3 is also conducted with the patient with the disease. The difference is with the number of population, number of the subject. And after conducted the clinical research, they will do a data review. They will evaluate whether this is really a good candidate that can be used as a new drug or not. And after that, the FDA, or in Indonesia we call it a Badan POM, will determine whether the application of the new candidate of new drug will be approved or not. If they approve, then it will be that means that the pharmaceutical industry can make them, and then can distribute and sell the drug to the public. And then after that, there are also the post-market monitoring or life cycle management. The drug development is actually a long and tiring investment. So actually, you can see that it's almost about 10 to 15 years to develop a new medicines, with a successful rate around 10%. So if basically out of 10,000 active compound, maybe only few will finally pass the clinical trial and can be marketed. So it is actually very big investment and high risk investment with a cost between the 800 million to $1 billion US. So this is actually really big investment. So actually usually now for the drug development process, the pharmaceutical industry will do some collaboration with the other industry. So they will do some cost sharing to generate money to sponsor this drug development program. So we will get to the question that why the drug development failed. So based on some literature, drug development failed because the drug does not provide the expected efficacy usually. The difference in the biological system between the human and experimental animal is one of the main cause why there are differences in effect when the candidate compound are tested in vivo and then they are tested in a clinical trial. So basically there is a different biological system between the animal experimental testing. So for example, in the animal testing, we use mice, a rabbit or monkey. And then after that, we determine that, oh, this is a good, the candidate have a good efficacy. But the problem is when they go to the clinical trial and then we collect the data of the clinical trial, it shows that there is no significant effect there is no efficacy, significant efficacy from the data. It means that there is a significant difference. Yeah. Sometimes the difference between the biological system is really affect the pharmacokinetic parameters, so that the efficacy of the drug when they are tested to the human is really different compared to when they are tested in the animal. So the difference in biological systems is actually also affect the safety of the product. So it has happened that the drug candidate that are declared safe toxicity tests in the experimental animal, and then it may still be toxic to human. This is also related to the biological system, such as metabolism or blood component composition, drug elimination, which make the pharmacokinetics profile the drug very different. So for example, if we compare the test between the animal testing phase to the clinical trial, we use the same dosage form. For example, tablet. We use tablet to the mice and we use tablet to the human. But the difference is the gastrointestinal tract from the mice is compare the human have a longer gastrointestinal tract. So for example, maybe the drug can affect the gastrointestinal more higher, significant or worse compared to the animal testing. So that's why in the clinical trial, maybe they also observe some adverse reactions or side reactions about related to the gastrointestinal problem. So that's why the safety and efficacy of the medicine often related to its pharmacokinetics profile. So as you can see in the graph here, diagram, the efficacy and safety is about almost 80% causes the drug development failed, and the other is more like a business things. The industry is I mean, considering that development this drug is not so prospective for the future, so they decide to stop the drug development process. So what is the important? What is the importance of the pharmacokinetic study? First, it's about I try to differentiate between the blue one and the red one. The blue one actually is, we call it, for maybe this belong to the group of pharmaceutical science. I mean, we dealing with how the drug can be metabolized, or why is the drug is not is poorly absorbed in the body. But for the red one, it's more like a clinical pharmacokinetics. It's the context is related to the patient is actually. So I try to different between the blue and the red actually. So for the toxic drug accumulation, by studying the pharmacokinetics, we can know the pharmacokinetics parameter that show drug accumulation, such as clearance, volume distribution. We can use this parameter to measure the potential accumulation of drug in tissue that can have a toxic effect in the body. So basically, if we know, for example, oh, the clearance of the drug is something, and then the volume distribution of the drug is something, and then we can decide whether this drug has a potential to become not become an accumulate in the body that cause a toxic effect. And then and a second importance is useful drug may have no benefit because the dose are too small to establish a this also the one drug that lack efficacy. Potential candidate compounds sometimes do not have the expected effect because their concentration is too small when they reach the target tissue. So usually such compounds have problem in absorption, distribution, or metabolism. So when we are studying the pharmacokinetics, we know that after, for example, after the route of administration, for example, in the intravenous administration or oral administration, we can measure the concentration, blood concentration, the drug in the blood concentration, so we can determine whether the drug concentration is effective or not to generate the efficacy. So when we identify that the drug is not given the enough efficacy, we also we can expect that the drug is not reaching the minimum therapeutic concentration in the blood. So that's why we need the pharmacokinetic study. So by studying the pharmacokinetics, we can determine where the drug problem lies. If necessary, we can modify the drug compound to improve the drug pharmacokinetic profile. So at the following slide, we will study about the after we know that, for example, this drug has a poorly absorbed in the gastrointestinal tract, so we can design another molecule that may be almost similar to the drug, but with the merits of the increasing physicochemical properties to increase the absorption, so they can enter they can easily enter the membrane. So for the rapidly metabolized drug, just like before, we can tell if a drug is rapidly metabolized if we measure its pharmacokinetic parameters. It is even possible to measure the metabolic outcome of the drug as is performed. For example, usually we perform it under drug therapy in cancer. For the cancer drug in monitoring drug therapy, we do some monitoring, therapeutic dose monitoring. So we take some of the patient blood after the interval time after he or she take the medicine, and after that we try to determine whether the drug concentration in the blood is still effective or not, is still reaching the minimum therapeutic concentration or not. And after that we can adjust the dose depending on the data after we do the therapeutic dose monitoring. So we can also actually, if the drug can rapidly metabolize, it is also possible we calculate or we determine the metabolite of the drug as long as the metabolites already has a standard that is available in the market. Actually, for the cancer drug, there is also metabolite form. The metabolite form is already available in the market. So for the therapeutic dose monitoring, it is also possible to calculate or to determine the metabolites after the consumption of the cancer drug. And after that, we can do some adjustment dose for every individual patient. So if the drug is rapidly metabolized, then a prodrug can be made. So it's also the same idea as can be applied before. If the drug rapidly metabolized, we can create a prodrug so that when it enters the body, the prodrug will be converted into the active drug will be metabolized into the active form that provide a therapeutic effect for the body. So it means that if before we face the problem of about the rapidly metabolized into the inactive form, we can make the prodrug so that after the metabolize, the majority will be an active form, so it can give the therapeutic effect to the body. Sorry. So for the 3 point in red, actually is the function is devoted to the clinical pharmacokinetics, the things that related actually directly to the patients. First is to individualize patient drug therapy. As I tell you before about the cancer drug monitoring therapy. So the problem is the cancer drug has a narrow therapeutic index. It means that, for example, to get a good therapy in the cancer drug, for example, you have to maintain the blood concentration level, for example, 50 microgram, for example, maybe 50 nanogram, let's say 50 nanogram per milliliter in the blood. But maybe on 70 nanogram per milliliter, it will become a toxic effect. So basically, something like a cancer drug actually has a narrow therapeutic index. So this is just small interval you have to maintain to get a therapy, to get a good efficacy. But if you get higher than that, it will give a really toxic effect. So such kind of drug, we do some monitoring drug therapy, yeah, so that the patient can have a great efficacy and we can minimalize the toxic effect of the drug. So that's why we do the monitoring therapy. So when at first we individualize the patient drug therapy. It means that after we do some, we get some the pharmacokinetic profile, we know the clearance, we know the maximum concentration, we can adjust the dose of every patient. So that means that patient A, patient B, even if the patient is get the same breast cancer, same stadium, for example, third stadium, maybe the therapy of the both patient is different. It's related to actually the metabolism activity of the patient. So that's why we need the pharmacokinetic study to adjust the dose, and after that we can determine the suitable dose of the every patient. So this is the description why we also will need the pharmacokinetics also. The duration of the drug therapy range from the single dose for the drug acute condition to the drug taken lifelong for chronic condition. So why we need the pharmacokinetics? Usually for the chronic condition, we need this. For example, some related to the cardiovascular disease. Usually we have to take drug for a long time, for a long time. For example, for diabetic, for the hypertension, usually we have to take the drug for in our life. So that's why in the chronic condition, we also need the pharmacokinetic study, because even after consuming the drug for a long period of time, there is some tolerance of the body in the body. So it means that the body also need the dose adjustments. The frequency of administration of drug in particular dose is called the dosage regimen. So basically, this is some dosage regimen is also some kind like definition the frequency of the administration drug in particular dose. And then I have already explained the absorption, distribution, metabolism. So this is the definition. I mean, this is the subgroup of the pharmacokinetics. I also told you before about the clinical pharmacokinetics. So I tend to divide the pharmacokinetics into two. It's a pharmacokinetics related to pharmaceutical science. So we can focus on what happened to the drug in the body. And then this one, the clinical pharmacokinetics, is more focused using the application of the pharmacokinetic principle in the safe and effective management of the individual patient. So it's basically for the monitoring therapy, yeah, for the dose adjustment. There's also the population pharmacokinetics. It's a study of pharmacokinetics difference of drugs in various population groups. There's also there is a study the comparison between the of the pharmacokinetic profile compared to the European country and Asian country, African country of the pharmacokinetic profile. And then the pharmacokinetic profile is used to adjust the dose in every region. Okay. There are also toxicokinetics. It is the application of the pharmacokinetic principle to design and conduct the interpretation of drug safety evaluation study. So what I show you, this is the plasma drug concentration profile versus time after the oral administration of the single dose. So basically, the basic of the pharmacokinetics and pharmacodynamics can be explained by this curve. As you can see here, maybe I try to write something here. Please wait. Okay. We will see this one is the minimum effective concentration, or we call it the MEC. And after that, this is the maximum safe concentration, or we call it the MSC. So basically, the drug have to be maintained in this interval to make a good efficacy. Produce efficacy. So I repeat that basically the product, the drug have to be maintained in this concentration to produce efficacy. Lower than that, we call it the subtherapeutic level, which means that the drug is present in the body, but it not if it's not given a good efficacy. And above that, it will reach the toxic level, which means that will generate the toxic effect to the body. So we have to maintain on this interval. So before I said that there is a drug with a low therapeutics index, which means that this interval is really low. For example, in the cancer drug, maybe the interval is just like this, really small interval. So it means that you have to be carefully maintain the plasma drug concentration. That's why we need the monitoring therapeutic drug monitoring. So this one, we call it the onset of actions. It means that because of the curve is getting from the oral administration, it means that after the consumption of the oral drug, for example, tablets, the drug will need time before he can achieve the effective concentration. The time the drug need to be reach the minimum effective concentration, it is called the onset time, which means it will generate the onset of actions. It means that the drug will start work. So after that, the drug will be in the interval of the effective concentration. This one is defined as a duration of the action, which means that the interval of drug achieve the effective concentration, and this is the termination of the action. And then for the pharmacokinetic profile, there is Cmax, peak plasma concentration, Cmax, this one. So it means that this is the highest plasma concentration can be achieved for the drug after single dose of administration, oral dose administration. In this graph, the Cmax is achieving the toxic level. So actually, we don't want that. Actually, so in the curve is just for the for the description, so that you can have a better understanding about the pharmacokinetics and pharmacodynamics. But for the use, we tend to make that the maximum concentration is also below the maximum safe concentration. This is MSC, maximum safe concentration, and then this is the minimum effective concentration. So for the drug use in the market, we said that the Cmax is also below the MSC. And for the more than one combination, I mean for example, if you consume another drug, it will maintain the drug concentration level in the interval of effective concentration. So that means that the second consume, for example, I will write in the blue, maybe we'll start here like that. So we can maintain the plasma drug concentration in the effective concentration all the times. So that's why for several drug you need to take it 3 times a day, 2 times a day. This is why. Yeah, this is why. So the use of the drugs is actually come from the pharmacokinetic study. Yeah. So that depend. Oh yeah, you can use just one time. You can take for 1 gram tablet, or you can use 2 times 500 milligram tablet 2 times a day. Every use of the drug is actually generated from the pharmacokinetic study. Okay. So this is just some several pharmacokinetics parameters. Like I said before, we will not go to the mathematical equation, since I told before that this is actually 2 or 3 credit course. It's actually running for the whole semester, around 14 module. So it is also it's also really different subject. Yeah, really it's quite a heavy subject actually. So right now I just introduced the definition for you, so you can basically grasp the introduction. Yeah, the introduction of the pharmacokinetics. This is some of the pharmacokinetics parameters. One is the peak plasma concentration. Like I told you before, for example, this is peak plasma concentration, the Cmax. It is actually expressed in a microgram per milliliters. It gives the rate of drug absorption. It's also maksudnya describe the rate of drug absorption. It depends upon the dose administered, rate of absorption, and rate of elimination. It's also in the following slide, I also introduce you about the several dose administration, route of administration. And also actually the route of the administration is affect these absorption parameters. The second one is the time of peak concentration of Tmax before. Let me show you previously in the previous slide. So this time, this is Tmax. So the Tmax is here. Time to reach the concentration maximum. Tmax. Tmax, and the AUC is actually the major pharmacokinetic parameter to use in a pharmacokinetic drug profile. So the AUC, or area under curve, it expressed as the microgram per milliliter time hours. It gives the extent of the absorption. It is the important parameter in evaluating the bioavailability of drug from its dosage form. So for example, what's the drug that have been you consume actually is not 100% absorbs, except it is you do some injection intravenously, like to the vena, venous. It will assume that it is 100% absorbed, but other than that, it will not 100% absorb. It means that several will be metabolized, several will be directly eliminated from the body, which means that we in the pharmacokinetic study we also make an adjustment. Basically, we have to maintain the drug in the interval of the therapeutic concentration. So that is the pharmacokinetic profile. Now I try to introduce you some drug administration route. There are several drug administration route. For example, the otic from the ear, like this usually from the otic, the topical, which mean like cream or ointment, or usually like drops. I think drops is more popular in Indonesia. Ear infections, so we kind of use more like just a drop for the ear infections. And there's also in the nasal spray and drops. And then there also rectal or vaginal. We use like suppository, gel, ointment. Maybe this is more common, especially in Indonesia, or pessary. Maybe pessary is not so common. And then ocular, there is a drops. For example, for eye infection, for eye irritation, we use some kind of eye drops. There's also ointment, cream or ointment, implant, insert, or contact lens for the ocular targeted. And also there's also oral. This is more, this is most common route of administration. Most common. Tablet, capsule, thin films, syrup solutions, oral dispersible tablet. So that the tablet is really, after entering the mouth, it is really high dispersible. Readily become a powder. Inhalations. So there is also dry powder, liquid spray, aerosol. For example, usually for the asthma. Yeah, for the asthma. There's also topical or transdermal, like ointment, gel, cream, patches, microneedle. This basically we apply to the skin, but usually for the microneedle is maybe this is for systemic targeted drug. Maybe for ointment, gel is more like localized. And there's also injection. There's a intravenous injection, intramuscular to the muscle, subcutaneous, intraarterial, intrathecal. This type, actually, I can explain it to you. I'm not an expert doing the route of administration. Maybe we can, maybe you have the explanation from the doctor or from the nurse for this kind of the route of administration, since it's just a different target. For the venous is a vein. For muscular is muscle. Subcutaneous is just the tissue between the first layer of the skin, actually, and other. So basically, for the absorption, we tend to use the vein or intravenous injection as the standard, since the drug which use the intravenous route of administration is assumed that is 100% absorbed. Okay, we can continue. So again, if you have any question, feel free to ask by raising hand first, or you can just type your question in the chat box. So basically, that's why I can share about the pharmacokinetics. So like I said before, I do not want to go deep to the mathematical equation, how to calculate the dose regimen and etc. I just give you some of the definition and then some of the basic principle, and then after this, we will go directly to the explanation of the absorption to the elimination. So the absorption is the process by which the drug proceeds from the site of administration to the site of the measurement bloodstream within the body. So again, we use some kind of definition that the absorption stop after the drug enter the bloodstream. The absorption, again, I repeat that the absorption is finished after the drug is entered the bloodstream. It means that if you use the intravenous injection as route of administration, it means that the drug is 100% absorbed. 100% absorbed. But if you use other route of administration, it means that the absorption is not 100%. It's more likely less than 100%. It's actually necessary for the production of the therapeutic effect. So if the drug is not absorbed, then it will not give a therapeutic effect, except, so there's also some exceptions, except for the localized drug. For example, cream for analgesic cream or ointment. For example, maybe you have some back pain or pain on the leg after a long raining, so you apply the cream, oh no, maybe for the analgesic cream is like, maybe there's also a kind like a systemic effect, so maybe like antifungal cream. For example, maybe the patient have some infection from fungi, jamur, fungal infections, fungi infection around in the skin. So maybe like Dactarian of some drug like miconazole, like here. Nah, this drug is like a localized drug. I mean, he directly attack the fungi or bacterial infections in the localized in the skin. So this is not be the case. I mean, this is like not in the domain of the absorption context. The absorption context is used for the systemic drug, which means that the drug it's need to enter the bloodstream first, and then after that it will go to the target tissue. So most of drug undergo gastrointestinal absorption. Well, why? Because we use mainly oral route of administration. So when you consume a drug, we use it by mouth. Okay, so that's why most of drug undergo gastrointestinal absorption. This is the extent to which drug is absorbed from the gut lumen into the portal circulations. So basically, to be absorbed, the drug have to enter the portal circulation so that it can go to bloodstream and then distribute to the target tissue. So the drug characteristic that affect absorptions, there are several things there. One is the molecular weight, ionization, solubility, and formulation. First is molecular weight. Generally, a drug with the low molecular weight, small molecular weight, for example, less than 500 molecular weights, is actually easier to be absorbed compared to the high molecular weight. For example, for the high molecular, that's why the treatment using the protein, for example, some kind like enzyme, some kind like protein, is usually used by injection, not by an oral. Since first thing is because the condition of the stomach condition, in the it's a very highly acid condition, so that the protein will not be stable according that condition. The second is because the absorption, because of the protein have a high molecular weight, it's unlikely that can be easily absorbed to the bloodstream. So secondly is about the ionization. Usually the not ionized drug, the drug with the non-ionized form is better in the absorption compared to the ionized form. It is actually caused by the ionization cause the drug is more like hydrophilic, I mean more like polar, and then the polar compound is tend to be rejected. I will show you later because of the characteristic of the membrane. The polar it cannot be passed through the membrane. And the solubility, this is important because in the pharmaceutical, actually the drug is there's also some classification according the solubility and permeability. So to the drug, for the drug to be absorbed, the drug has to be solubilized first in the condition of the gastrointestinal condition. So even if the drug cannot be dissolved completely, it means that the drug will be poorly absorbed. Also for formulation, but I won't go explain too much about the formulation. So there is also factor affecting the drug absorption related to the patient. First is route of administration. This is why I told you before, there's a difference between the intravenous and oral or rectal administration. And gastric pH is also, the gastric pH is related to the form of ionization. So the ionization usually related to the pKa value. The pKa value is related to the gastric pH. And of course, and the contents of the GI tract. There are also some cases that if one component present in the GI tract, dominantly, the concentration is rather high compared to the other, it tends to change. It tends to change the absorption of the some compound, usually in the some metal absorption. There is also some modification because of the content of GI tract. So what I want to describe, this is again, there is a difference between the oral and intravenous administrations. For the intravenous administrations, the drug will be absorbed immediately. I mean that if we use the intravenous injection, it means that the drug is almost 100% enter the bloodstream immediately. If you use a bolus, the intravenous, if you use, there's two type, okay? I have to explain it. For injection, there's some two type, like we call it a bolus. It means that all drug enter the bloodstream. Enter the bloodstream immediately. There is a infusion. The drug enter the bloodstream. So for the infusion, we adjust the drug that can enter the bloodstream. For the bolus, it means that all the drug is enter bloodstream immediately, simultaneously. So IV drug is immediately absorbed and the oral is delayed because, like I said before, for example, in the case of tablet, the tablet need to be disintegrated first. Disintegrate to become a granule, to become a powder. And after that, it is dissolved. And after dissolved, it is absorbed. So that means that the oral drug, for example, tablet, need time to be absorbed to the bloodstream. So the second difference, the IV drug is completely absorbed. It means that all the drugs enter the bloodstream, but the oral drug is only partially, because there is no, I mean, we can say that there is no 100% oral drug that 100% absorbed to the bloodstream. There's always a species, some part of the drug that will go through the elimination process, do not go to the absorption, which means that only partially drug will be absorbed. So what happened in the absorption process? So for the absorption process, especially in the GI tract, in the gastrointestinal tract, the compound are called absorbed if they can pass through the phospholipid layer. This membrane consists of two-layer phospholipids that have a hydrophilic polar. I mean, this is part is hydrophilic. Which means this is polar, and this part is the tail form is the hydrophobic. This is a non-polar. So basically, for the kind in general to be easily absorbed, a compound needs to have properties that are not too polar and not too non-polar, because the compound basically need to go outside, from the outside to the inside, like this. The process of absorption is from the outside to the inside. So basically the compound needs to go through, whether it is a polar form, polar region, or the non-polar region. So basically it's not the good one is not so polar and not so non-polar. However, in general, the non-polar compound is tend to are easier pass through this membrane compared to the polar compound. That is for the passive diffusion. So it is important that the compound can be non-polar enough to reach to so that it can pass through the lipid bilayer. So other than that, also there's a passage through membrane to reach blood. So for example, there's a active transport or some like the exchange so that the compound can enter the bloodstream. So next slide, this is the explanation about how the ionized drug is actually more like have some good permeability compared to the ionized drug. So actually the unionized drug, this is can be adjusted by the situation, the pH or the pH situation is in the gastrointestinal tract. So for example, that's why in the drug information, we also considering how the drug is consumed, when the drug is consumed. For example, after eating or before it, for example, or if there's some significant amount of or significant aspect that need to be considered, for example, during the in the absorption process. Usually in the drug information, there's also some information that this drug is also need to be consumed with other food, for example. This is one of the reason why, because we want to make the unionized drug is more likely form in the gastrointestinal tract. So we for example we modify the pH, gastric pH. I mean, we modify drug is unlikely to be formed compared to the ionized drug, because this is like a balance equation. So sometimes the ionized drug is more likely to be formed, or unionized drug is more likely to be formed. So we want to use this one so that it can have the good permeability to enter the membrane. So there is also to decide whether the compound can have a good absorption or not. There is also rule for this. It's actually kind of days is maybe you learn it in this in silico study. There is also some AI to predict what is the compound that is good for absorption in the body or not. Yeah, this one's the Lipin rule of 5 is actually some older method to predict actually. So poor absorption or permeation are more likely when first there are more 5 hydrogen bond donors, or molecular weight is over 500, or the log P is over 5. I mean, is the if the log P is the ratio between the form dissolve in the octanol and water. So it means that over 5 is really hydrophobic. But recently, before we learned that the hydrophobic compound is tend to get easily to absorb. However, if it is too hydrophobic, it's also cannot be absorbed because it's tend to stick in the phospholipid bilayer, so it cannot pass through to the membrane. It stay to the layer. There are more there are more than 10 hydrogen bond acceptor. These 4 parameters can be used for the drug candidate to evaluate whether the drug candidate can be absorbed or not. So actually, after the absorption, after the drug going to the absorption, there's also the first pass metabolism. The first pass metabolism is done by the liver. So after the dose is entered, for example, the gastric or the gastric intestinal, and after that this is entered to the it will be metabolized. The metabolized is mainly conducted by the liver, doing some the metabolism. This is it means that this metabolite, it means that in this picture the metabolite is maybe it is assumed an inactive form. So the drug that will not be metabolized is then going through the bloodstream and become the definition of the bioavailability. So bioavailability is the fraction of administered dose reaching the systemic circulation. So, and then after that, we can calculate the bioavailability of the drug. How to calculate the bioavailability of the drug? Actually, by comparing the AUC of the oral of the AUC of the IV. The AUC of both oral and IV actually obtained from the experiment. So after we obtain the AUC both from the oral or the IV, we can calculate the bioavailability of the oral. So this one is group almost same as before. This is the plasma concentration of drug and time. So as you can see, the curve of the IV drug, it will not have a time of onset time because the IV drug will have 100% simultaneously go to the bloodstream. Means that all is ready enter the bloodstream, high concentration compared to the oral route. So drug given by intravenous route will have an absolute bioavailability F1 or 100% bioavailable, while drugs given by other routes usually have an absolute bioavailability of less than 1. The absolute availability is the area under curve of non-intravenous divided by the AUC intravenous. So we can determine the bioavailability of oral or other route. So maybe this one is I already explained to you the therapeutic index. The therapeutic index is the degree of separation between toxic and therapeutic dose. So it means that this is the therapeutic window. This is the minimum effective concentration. This is the maximum safe concentration. So the drug, again, has to be maintained in this interval, in this area. So the relationship between the dose, therapeutic effect, and the toxic effect, we can usually we describe it like here to describe the therapeutic index. So this one, the blue one, is the definition of the therapeutic effect, which means that in this part, it means that the therapeutic effects is reached for the 500 population. And the red one is for the toxic effect. It means that this one is the toxic dose for 50% populations. So the therapeutic index is divided. I mean the interval between the ED50 to the TD50. Now we move to the distribution. We finish with the absorption. We now move to the distribution. The definition of the distribution is the movement of drug from the blood and to and from the tissue. Since the distribution is not involving one way, but a two-way, from the bloodstream to the target tissue, and then from the target tissue to the bloodstream. So basically, the drug will enter the blood as the extracellular fluid in the inside of the capillary endothelium, and then go to the interstitial fluid, and after that we will across the lipid membrane and go to the intracellular fluid to reach the target tissue. So maybe one of you still wondering why, if we got a headache, why we consume the obat orally? Why just not why we just inject the, I mean, why don't we use the cream in the head, for example, or just injection? There's a lot of factors to consider. But when we use some kind like a systemic drug, for example, we use the drug that enter the bloodstream, it means that the drug need to be distributed to the target tissue. So the drug distribution is determined by, first, the partitioning across the various membrane or membrane permeability. Jadi how the membrane permeability can facilitate the drug to enter the target tissue. So this is depend on the cross membrane to the site of the action. And then the other one is the binding to the tissue components. For example, like some kind like molecule like calcium is really good, have the strong bind with the bone tissue. So binding to the tissue components is also it's also determine whether the effectivity of the distribution. For example, there's also some toxic substance like pesticides or heavy metals that has a strong bind bone or to the targeted tissue like kidney. Then after that, this is significantly give a toxic effect to that tissue. So it's really important to consider the binding to the tissue component. And other one is the binding to the blood component, like a blood cell or plasma protein, especially plasma protein binding, because if the drug have a strong plasma protein binding, it do not tend to cross the membrane. I mean that it tend to stick with the plasma protein. It means that the drug will just circulate in the bloodstream without going to the animal tissue. So the plasma protein binding is really important consideration of the distribution aspect. Because even if the drug is absorbed completely or good absorption, if the drug has a plasma protein binding, it means that the amount of the drug that can achieve to the target tissue is small. So we need to consider that. And then there's also some consideration, for example, in the case of malnutrition, for example, the albumin concentration of the albumin is really low than compared to the normal. It means that the free drug is concentration of the free drug is increasing. Increasing of the concentration of the free drug will increase the will increase the chance of the drug achieve to the target tissue or the other tissue, which means that maybe it can achieve the target tissue, but the other tissue will also have that drug. It means that there will be also an adverse reaction or side reaction. And the volume distribution and the lipophilicity of the drug. For example, for the lipophilic drug, it tends to accumulate in the adipose tissue. So other things is all the fluid in the body refers to the total body water, which a drug can be dissolved, can be divided into 3 compartments. I mean, for the distribution, we tend to we make the definition to simplify how the distribution process in the drug distribution process. First one is the intravascular. This is, for example, blood plasma found in the blood vessel. That is the intravascular. There's also interstitial or tissue. This is the fluid surrounding cells. And then also intracellular. This is the fluid within cell. For example, the cytosol. The distribution of a drug into this compartment is dictated by its physical and chemical properties. So the physical and chemical properties of the drug is determine the distribution of the drug. So this is actually the body fluid compartment. So we to about 67% of the total body water is the intracellular fluid. It means that it is cytosol. And then the extracellular fluid, about 33% of total body water, which divide about 75% is the extracellular fluid, and 25% the extracellular fluid, plasma fluids like in the bloodstream. And the 75% is the interstitial fluid or extracellular fluid. So how we define the volume of distribution? The volume distribution is the amount of the drug in the body, the ratio of the amount of the drug in the body compared to the plasma drug concentrations. So that's why volume distribution of the body is not describing the volume of total body water. It's different. It's actually comparing the capacity of the drug, distribute in the body. So this is the different of volume distribution of the drug. That's why. So don't make it maybe at first it is strange why some kind like haloperidol have about 1,400 liters. But however, the total body water in our body is not like that. This is a different definition. Again, this is describe the capacity of every drug can distribute in the body. The factor affecting the volume distribution of the drug, first is blood flow. This is rate vary widely as a function of tissue. For example, in a muscle is a slow, in the organ is a fast. And for the capillary structure, for example, most capillary are leaky and do not impede diffusion of drug. For example, in the capillary, there is a chance that small particles, small or few drugs, particle of drug will leak, or I mean, there will be a diffusion, which means it will be lost before it will reach the target tissue. There's also blood-brain barrier. This is important blood-brain barrier is formed by high-level tight junction between cell. It basically non hydrophilic or very hydrophobic region. So basically only a high hydrophobic enough drug can enter the blood-brain barrier. So this is like final protection from the final protection so that the brain can be protected from the other toxic compound. So basically the BBB 3B is impermeable to most water soluble drugs. So it is just like I explained it before, the plasma protein binding. Many drugs bind to plasma protein in the bloodstream. And then because of the binding to the plasma protein, it limits the distribution because it tends to stick with the plasma and that the drug doesn't want to go away from the plasma. I mean, it cannot reach the target tissue. It means just distribute to the bloodstream. The drug that bind plasma protein diffuse less efficiently than drug that doesn't. So it is important to consider if the drug with a consider the plasma protein aspect because it's really affect the distribution process. So the distribution is actually also determined by the physiochemical properties, or we call it one of the physiochemical properties is the partition of the coefficient oil water. Partition coefficient of oil water. Almost same like log P. So, but in our thing in the pharmacy, we also use this for other concept. So the partition coefficient oil water can be used to determine whether drug likes to go in the body. Any drug with the partition oil water greater than 1 will diffuse through cell membrane easily. It means that it can be distributed through all the 3 fluid compartment. It means that it will be well distributed to all of the tissue. However, for drug with the low PO water value, meaning that they are fairly water soluble, are often unable to cross and require more time to distribute throughout the rest of the body, which means that we will have more time. We will need more time to reach the target, and we'll need more amount. So this all of this aspect really consider to 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 evaluate and that should we do for the every treatment. So other physiochemical properties is the size of the drug. I will not go farther for this since already explained. So most drug size also determine whether it can go in the body because it's also important. The molecular weights is around 250 and 450. For the tiny drugs like caffeine, it can passively diffuse through the cell membrane. As for the antibody or the other drug range, this one is rather different. For example, more than 200 Dalton cannot passively cross membrane. Will require specialized protein-based transmembrane transport system, which means that it will make a slower distribution. So something like a protein is not can be distributed by the passive diffusion. So it will need a specialized protein-based transmembrane transport system. It means that the distribution is lower. The drug less than 1,000 Dalton have the high PO value simply diffuse between the lipid molecule that makes up membrane, while anything larger requires specialized transport. So if there are some lipid with the low molecular lipid, maybe they also can do with the simply diffusion, passive diffusion, but also slow because of the size. However, this is still possible, but for the higher more than 1,000 Dalton, it is require a specialist transport. So as for the elimination, the elimination is consists of two. There's an excretion and metabolism. And for metabolism, so the definition of the elimination is the irreversible removal of the parent drug from the body, which consists of can be metabolism of excretions. And for metabolism, basically we can do some offers, sorry, for the elimination, we can do the pulmonary, this expiration to the air, bile. I mean, it is done by the liver. So it will be excreted in the feces for the intrahepatic circulation. And then it can go by the renal or the kidney in the kidney, going to glomerular filtration, tubular reabsorption, tubular excretion, so become urine. For the metabolism, basically, all the drug can undergo metabolism. So both drug and toxin are actually same. This recognized as foreign to the patient body. So it is almost natural the body do some the chemical modification of drug for the overall goal is getting rid of the drug. So actually the metabolism is not like the process to change inactive form to become active. Actually the process to change the drug so it can be easily eliminated in the body. So it means simplify it. We can simplify that the drug will be metabolized to make more polar, water-soluble drug, and so that it can easily excrete it or eliminate it in the body. So drugs can go metabolism in the lung, blood, and liver. I already explained it before. The body works convey drugs, less active form. Increase this one, yeah. The convert drug into less active form and increase water solubility to enhance elimination. But it doesn't mean that the metabolism always change the drug into the inactive form. Sometimes the metabolism also change the drug into the toxic form. So it means that if there is any, for example, non-toxic materials, but there's also possibility that if it is enter in the body and it is metabolized by the body, for example, by liver, it can be converted into the more polar substance. However, the more polar substance doesn't always related to the more safety compound. It can also be more toxic compound, then can be affect the body. So these things also to consider. The enzyme are typically involved in this metabolism. So for the example, for metabolism, this is from 1898 through the 1810. Heroin was marketed. This is just some historical background here. Was marketed as non-addictive morphine substitute and cough medicine for children. But it is 100 years ago, remember, 100 years ago. Bayer marketed heroin as cure for morphine addiction. And then heroin is converted to morphine when metabolized in the liver. Of course, today this is also is banned. I mean, we not use this anymore. This is just heroin is just narcotic substance that really banned in every country in the world now. So for the metabolism, we can divide it into the two phases. There's phase 1 and phase 2 reactions. For the phase 1 reaction, it's actually a convert a parent compound into more polar. So the phase 1 reaction, it is convert the parent compound into a more polar or hydrophilic metabolite by adding or masking functional group. For example, the hydroxide to amine, carboxylate, thiol, for example, doing some oxidation. So often, these metabolites are inactive, so maybe sufficiently polar to be excreted readily by cytochrome P40 450 system located with the endoplasmic reticulum hepatocyte. And through the electron transport chains, a drug bound to the CYP450 system undergo oxidation or reductions. So basically, the phase 1 reaction is mainly done by the cytochrome P450. So it is of course by the enzyme induction. However, because of the enzyme, we have to consider the drug interaction. Because for example, in the case of the use of more than one drug, we have to consider the metabolism process of the H of drug, whether it will be affect the pharmacokinetic profile of the drug. So the next is phase 2 reaction. It's mainly the conjugation reaction. This is the conjugation with the endogenous substrate to further increase the aqueous solubility. So for example, after the process of oxidation, the product after the oxidation will be conjugated with the other endogenous product, so it can be eliminated easily. Usually conjugation with the glucuronide, sulfate, acetate, or amino acid. Polar group is conjugated to the drug, which means that this is the context we make the polar compound to be more easier to eliminate. So basically the metabolism is mostly occur in the liver because all of the blood in the body pass through the liver. So that's why in the case of the patient, which need to consume a lot of drug, a lot of medicine, maybe in the future we also have to consider the liver function. Because if we consume a lot of drug, a lot of medicine, it means that the activity of the liver is high. I mean, the pressure of the liver activity is also, we have to consider whether the liver function is still good or not. So, as I told you before, the most important enzyme for the metabolism is cytochrome P450 monooxygenase family. It's actually act on structurally unrelated drug. All of the structure compound passed through the liver is going to be changed by the cytochrome P450. This is metabolized the widest range of drug. And this CYP family of enzyme is found in liver, small intestine, lung, kidney, and placenta. Consists of the 50 isoform. Major source is for catalytic activity for drug oxidation. It's been estimated that 90% more of human drug oxidation can be attributed to main enzyme, this Y, CYP. In different people, different population, the activity of CYP oxidase difference. So that's why we study the population, pharmacokinetic population, because of different population, also different in the drug metabolism. This is just some, some issue about the codeine use. Yeah. Codeine linked with the breastfeeding danger, warning to class action should follow the Toronto neonat poisoning death. So Asian and African babies are at greater risk of rapidly metabolizing codeine. So this is also a point to consider regarding the metabolism of the codeine. In the metabolism, actually, for example, the enzyme, there's also several things that can inhibit the enzymes. For example, the inhibitor like cimetidine. This can prolong the action of drug or inhibit the action of this biotransform the agent. And there is also the inducer like barbiturate or carbamazepine that can also shorten the action of drug or increase the effect of the biotransform of active agents. Or there's also a blockers. This is acting on non-microsomal enzyme like a monoamine oxidase on anticholinesterase drug. So actually many of drugs can induce or affect the activity of the enzyme. So that's why in the drug information, there is also information regarding the drug interaction or drug adverse reaction or something like that to educate the health practitioner the risk of the use of the drug, especially when combined with the other drug. So usually we study like this kind is to determine the drug interaction. So again, we back to the phase 2. Main function of the phase 1 is to prepare chemical for phase 2 metabolism and subsequent excretion. Phase 2 is actually the detoxification step in the metabolism process. So mainly the phase 2 reaction, there are several reactions. There are glucuronidation, which is the most important part. There are sulfation, acetylation, amino acid conjugation, glutathione conjugation, or condensation reaction. And as for glucuronidation, this is the important phase 2 pathway for drug and endogenous compound. This is component. This is mainly the conjugation of the alpha delta glucuronic acid. The products are often excreted in the bile in the liver. So for the summary in the metabolism, the product phase 1 and phase 2 for metabolism, the product are generally more water soluble. And this reaction actually for preparing for the excretion. So actually, I have to remind you again, the metabolism is a process to preparing for the elimination, make more polar compound to as to easier to eliminate, not to convert to the non-toxic form. It's not always the metabolite form is not always the non-toxic form. There are many complementary, sequential, and competing pathway in the metabolism. Phase 1 and phase 2 metabolism are a couple interactive system interfacing with the endogenous metabolic pathway. So actually we cannot separate the path 1 and path 2. Actually, it is actually a couple interactive system to metabolate especially in the drug metabolism. And for the excretion, the main process is body eliminate unwanted substance, most commonly the biliary or renal, or through the feces or the urine, other route to the lung through exhalation, or the skin through perspiration. And lipophilic drug may require several metabolism steps before they are excreted, because lipophilic drug will be converted to the more polar until it is polar enough to be easily excreted, and then it will be excreted. And then this is the last of my slides, actually the summary of the absorption, distribution, metabolism, and excretion. So basically absorption we're handling from the oral administration. I mean, after the drug entered the GI tract, and then after that, how we study how the drug can enter past to the membrane to the bloodstream. We call it the absorption from the intestinal absorption. And after that, it will go to the first pass effect to the mainly to the liver. The first pass effect in the liver will undergo the metabolism. And after that, it will go to the blood, and then it will be distributed to the tissue, target tissue. And we have to consider whether it is unbound or bound, whether they are the plasma protein or not plasma protein, whether the plasma protein involved in distribution or not, like I told you before. And then this will affect the distribution of the drug, whether the drug can be distributed from the blood or to tissue or not. So after the target tissue, whether the drug can achieve the site of action or not to make the pharmacological effect. And after that, the drug will be back, and then doing some metabolism again to the excretion by the biliary excretion, or the renal excretion to the urine excretion. So I think this is the end of my talk. Thank you very much again for your attention. I will give it back to moderation. I hope that there's still time for the Q&A session. Thank you very much.
Yeah, thank you very much, Dr. Catur Jatmika, for the interesting and very comprehensive presentation on the principle of pharmacokinetic and ADME, which are not only important for academia, yeah, but also for industry practitioners, because these concepts must be deeply considered to produce drug compounds that meet the quality standard and pass the testing. And okay. Because of the time limitation, yeah, but we still have the question and answer session. I believe that all students have big curiosity about the principle of ADME, and I believe that you want to know more about this topic of the lecture. So please use this session to discuss with Dr. Catur Jatmika. Maybe first one is Hezron.
Hello, doctor. Can you hear me?
Yeah, please.
Okay, please.
So I have a few questions that I want to ask from the start. So my first question is, based on the absorption part, there are some of the factors that affecting the drug absorption, right? Which is like the contents of the gastrointestinal tract. What is like the example of the contents of the GI tract? So that's my first question. And then my second question is for the distribution of the drugs. Usually we use like the blood cells, like plasma but can we use like bone marrow as the distribution for the drugs? I think that's all.
Okay, thank you very much for your question. It's important questions. According to the first question, the context of the content of the GI tracts. It's actually depend, but for example, the content, as we know that the content of GI tract is also about food, right? So maybe the nutrition, for example, maybe the content of the vitamin, minerals, or some other major component food like a carbohydrate, lipid, or proteins is also can affect the absorption of the compound. So and actually for the drug, I'm afraid that I cannot give you much example for, but as for the since my I have actually have lecture in the metal toxicity, cap metal toxicity. So to according to absorb the important metal like zinc or like a calcium, it's also important to have sufficient amount of the vitamin. So maybe for the drug is also like that. The sufficient nutrition. It's also important to so that the so that the so that the drug can be effectively absorbed into the bloodstream. That's one of my answer for the question one, and for the second. As for the distributions, actually I explained about the major distribution process that is used for the systemic drug is use a blood, that is a blood cell or plasma protein. However, it's also possible. It also as also possible. It's also possible doing using something else, especially if you use the other route of administration. For example, if you use the local injection to the site like the near the bone marrow, for example, it's possible to use the distribution system distribution like that. Or if the drug have been modified or specifically targeted to the bone marrow, it will go at first at the bloodstream and then enter. If the drug have some, you mean good related to the bone marrow, I mean good connection to the bone marrow, it will finally achieve or can achieve to the bone marrow tissue. I think that is my answer. Thank you.
Okay, understood, doctor. Thank you, doctor.
Yeah, thank you, Dr. Satur, and also thank you for his own question. Yeah. Okay. Is there any questions? More questions? Yeah, from Raihan. Yeah.
Excuse me, can you hear me, doctor?
Yes, please.
My question is, I remember on
Can you, I mean, I think the voice is too small for me. Can you increase your volume?
is this audible?
Okay, okay.
I
Better.
think I remember listening on the distribution chapter. Among one of the factors that affected it is binding to tissue compounds and blood components. What I am curious is, what are the usual characteristic of drugs that cause them to have a tendency to bind to tissue components or blood components?
Okay. For example, for the characteristic for the drug that can be bind to the tissue component, is actually we can right now we can predict during the in silico study actually. So usually if we already get into the pharmacokinetic trial, I mean that it means that the drug has been accepted for the clinical trial. It's also have been designed that it will have a good binding to the tissue component. So before it will have it has been designed that it's have a good binding tissue to the tissue component. However, for plasma, I think on the for the binding in the plasma protein part, it's also we also get the data from the pharmacokinetic study. Then after we can get the pharmacokinetic profile, we can know that this drug is have the good, I mean high binding to the protein plasma binding, so that it can I mean, it's rather maybe it's rather hard to be going to the target tissue. However, this whether which strong binding that is also point to consider, which is if we can design the drug have binding tissue is better compared to the binding to the plasma protein, it will be great, because at first, if the plasma protein binding is good, which means that it's easily distributed, and after that, if the drug meet the target tissue, the drug should be allowed to contact to the target tissue and leaving the blood, leaving the protein plasma. I think that's my answer.
All right. Thank you, doctor.
Okay, clear, yeah, from Dr. Chatur, clearly explained. Is there any other question related to the pharmacokinetics and ATME study? Okay, Adam Crowther, please.
Hello. I just a question about the CYP enzymes. So if they're very specific, how can they interact with how can they metabolize 90% of most drugs that are, of course, sent through the liver, if as enzymes they're very specific to a certain type of molecular structure? That's just my question.
Okay, thank you very much. The term of specific, I think, is not. I mean, we can say that the CYP enzyme is only generate not. What I can say, the term is specific, maybe it's not quite accurate for that term, because mostly I mean 90% of the compound is metabolized by this enzyme. So I think maybe this enzyme only identify some part of the molecule, for example, maybe the carboxylate part or the amine part of the compound, or some general part that can be identified, and then after the enzyme identify that part, they change the parts, for example, because mainly for the oxidation reaction, and then it's converted to be ready for the phase 2. So maybe it just recognize the other part of the other general part of the every compound, so that it can change or it can modify it into the more polar substance. I think that's my answer.
Okay. Thank you, Doctor.
Yeah. Okay. Okay. Three three more questions and also a comprehensive answer from Dr. Chatur Jatmika. I will give one more chance, one more question if still there is question or discussion from students and attendants. Is there? Okay, maybe because of the time limitation. Yeah, I'd like to summarize maybe yeah, only
One question
small.
there is question in the chat group, Dr. Bayu.
Okay, sorry. Okay, from T Chiawin, yeah. Dr. Chatur, could you please explain how blood flow affect the volume distribution of the drugs?
Okay, about the blood flow is actually affect the equation of the
Sorry, Dr. Chatur, maybe the volume, your voice.
okay, wait. Okay, is this audible enough?
Yes.
Okay. Okay, for the blood flow actually affect the calculation of the volume distribution, since the blood flow is affect the amount of the drug in the body for a certain time, because I mean for the in the sampling process there's also the amount of the drug will affect by the blood flow. So it means that uh will generally affect the volume distribution. I think that is my answer.
Okay, thank you very much, Dr. Chatur. Yeah, I believe that more students want to ask more question and want to know better about this topic. However, because of the limitation time, we have to yeah, enough here. So maybe from me as moderator to summarize the lectures. This lecture is about the pharmacokinetic and ADME, and is crucial in drug development because these factors can determine the drug efficacy, safety, as well as dosage. Yeah, understanding how a drug is absorbed, distributed in the body, metabolized, and excreted helps predict its therapeutic potential and minimize the adverse effect. And this knowledge guides optimization of drug properties, ensuring it reach the target site at therapeutic levels without causing toxicity, and ultimately influencing the drug's success in clinical trials and its overall effectiveness. Okay, we come to the end of the lecture session. I'd like to say thanks again for my best friend, Dr. Chatur Jatmika, for his informative lecture. And also thank you for all of the participants who attend this meeting or lecture. Thank you very much. I will give back this time to Miss Hilna as Master of Ceremony for today. Thank you, Dr. Satur, and thank you everyone.
Thank you very much for our moderator, Bapak Dr. Bayu Ardiansyah, SSI MSI. And thank you very much to Bapak Dr. Apoteka Catur Jatmika MSI for your insightful and comprehensive lecture on participle of pharmacokinetics and ADME. Your expertise and clear explanation have greatly enhanced for our studying in this field. Ladies and gentlemen, now we come to the end of today's agenda. But before we conclude, we will take a moment for photo session. The photo session will be guided by Rohman. For Rohman, time is yours.
Okay, guys, please open your camera. Okay, 1, 2, 3. Okay, again. 1, 2, 3. Okay, thank you.
Thank you very much for Rohman and all of the participants in photo session. Before we part way, I want to remind next lecture about bioassay technique for drug development with Bapak Dr. Muhammad Kumail bin Abdul Wahab from University Malaya, and will be moderated by Ibu Dr. Isnaini Rahmawati, SSI MSI. So please make sure to join us at the same time on Thursday. Thank you very much for your kind attention. Have a great day and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much again.
Thank you very much, Pak Catur.
Thank you, doctors.
Thank you very much.
Thank you, doctors.